All right, good afternoon. Welcome to Chapter 9, Patient Assessment. EMTs, this is the #1 lecture. You really need to get this because you'll be challenged all throughout the rest of your program and throughout your career with patient assessment. It's not that difficult. You just need to really remember 4 key components. That's scene size up, primary survey, secondary survey, and also reassessment. Now there's some other components that we're going to add to that is a part of patient assessment. But overall, those 4 things are your structure. So let's get started. All right, so as an introduction, you need to be the master of patient assessment. This is the one thing you'll do over and over and over again. The assessment process is divided into 5 main parts. I call it 4 main parts, but we'll talk about the general impression as well. Rarely does one sign or symptom show that the patient's status or the underlying problem. You have to be a detective. You got to put that old critical thinking skills in place to be able to determine what's wrong with your patient through a good assessment. So scene size up, it's your evaluations and conditions you'll be operating in. Maintain situational awareness all the way around you. 360 degrees, man. You need to know what's going on. Otherwise, something's going to happen. You're not going to see it coming. You're going to get hurt or even possibly killed. Scene size up combines an understanding of the situation itself and conditions prior to responding. Dispatcher gives you all the basic information, and then of course you get the rest of it through what we call the windshield survey. That's the observation as you're pulling onto the scene, and then other observations that once you get out and we start looking around. Issues can range from minor difficulties to major dangers. Don't enter the scene until it's safe for you and your team. Most commonly when we're responding, we respond to a staging area until such time that police arrive and they can ensure your safety and the scene is safe. Make sure that if it's a motor vehicle accident of any way, shape, or form, or even a boating accident, that we have traffic safety issues and that you need to make sure that you're safe and that you set up a situational awareness or a safety net around you to protect you. One of the biggest things that you can use is be visual. Put on a reflective vest. They aren't the most Gucci looking thing, but you need to wear them. They will save your life. We work in all environmental conditions, whether it's raining or whether it's hot or whether it's hailing or whether it's snowing. It does not matter what it is. People get hurt and EMS does not stop. We're kind of like the mail. Through rain, sleet, and snow, it doesn't matter. We have to deal with it. And hurricanes, tornadoes, volcanoes, earthquakes, all that stuff. All right, so specific ensuring safety, we're talking about forms of hazards, the environment itself. Is there anything that's fire or electrical? Is there lightning? What could be a potential hazard from the environment? Physical, is there somebody standing there with a baseball bat? That's never a good plan. Chemical, electrical, I think they speak for themselves, but specifically on the electrical, especially automobile accidents, remember that even if the line hasn't fallen, it could sag because when the poles get bent, okay, the wires themselves that are attached, they now sag. So you can run into one of those very easily. And then, of course, water, fire, explosions, and any physical violence. Be aware of scenes that have potential for violence. If it's a domestic dispute, if it's a large crowd of people, an emergency scene is a very dynamic environment. It changes constantly. That's what that situational awareness is all about. Once you lose that, you can't get it back, because if the scene gets chaotic because you lost your situational awareness, it's usually too late. You're either getting hurt or you're getting mowed over by something. All right, so determine the mechanism or nature of illness. This can be categorized by medical condition or traumatic injuries. Either it's a MOI, okay, MOI, whoop, there I am, or it's an NOI, nature of illness. So mechanism of injury or nature of illness. With our mechanism of injury, we look at from the traumatic side, is it a blunt injury, otherwise it is an injury that did not penetrate the skin, or is it something that penetrated? Determining that mechanism, medical patients, we determine the nature of illness. Is it chest pain? Is it respiratory? Is it an abdominal complaint? Is it a diabetic complaint? Those kind of things. Be aware of scenes of multiple patients exhibiting similar signs and symptoms. This could indicate an unsafe scene. And yes, you could still have both. You can have a mechanism of injury or a nature of illness at the same time, because many people are driving, they have a stroke, they have a heart attack, and then they crash, and that causes the trauma. So considering the MOI or NOI early can be of value in preparing for the care of the patient. We need to spot these things immediately, especially in mechanism of injury. How significant is it? Is it, a fall from 3 feet or a fall from 30 feet? Those kind of things. Big difference. All right, so wear your personal protective equipment, your PPEs. As you can see here, this gentleman is putting on a face mask along with his goggles. Should be adapted for whatever pre-hospital task is at hand. These are our standard precautions. Standard precautions have been recommended for the use in dealing with objects, anything with blood, or any bodily fluids or other potential exposure risk of communicable diseases. When you step out of the EMS vehicle, you need to have standard precautions. I tell you, folks, eye protection and sunglasses don't cut it. They need to be, whatever you're wearing needs to wrap around, and you can't have something that your eye protection is filtered or shaded, because what if the scene's dark? You're going to need to be able to see. Or what if the light conditions change? Because when you're outside, it's bright. But when you walk inside now, you're at regular light, so you need to have a good pair of safety glasses. Wear them around your neck at all times. It doesn't mean you can't wear your sunglasses. You have both. And then when your safety glasses, it's time when you get up close, you can put your sunglasses on top of your head. But I always have mine on a pair of croquis or a lanyard, because I lose them, drop them, and yeah, no. At minimum, gloves must be in place. And then consider glasses, some kind of safety glasses and a mask. All right, so determine the number of patients. During the scene size up, we need to accurately identify the total number of patients. This is critical in determining a need for additional resources. If we have more than what we can handle, we got to call for help. We need some support here. When there are multiple patients, use the incident command system and identify the number of patients and begin triage. All right, so consider additional specialized resources. ALS, if it's, if you think you have a patient that needs advanced life support. If a patient needs to be flown off scene, you're going to need air medical, fire departments, law enforcement. As you can see in this particular photograph, these guys are set up for level A hazmat. They are wearing the top notch. They've got everything on to be completely protected against any kind of hazardous material. Determine if you require additional resource. You need to ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And do we have the resources to respond to their conditions or treat their conditions? If you answer no to any things or a negative response, you need to get help. All right, so primary assessment. This begins when you greet your patient. The goal is to identify and initiate treatment or immediate potential life threats. You need to physically examine the patient and assess for the level of consciousness and also the ABCs. The general impression is formed to determine the priority of care. It is the first part of the primary assessment. So you're going to make note of the person's age, sex, and race, their level of distress, are they in acute distress or non-acute distress, and their overall appearance. Note the patient's position. Avoid standing over the patient and address the patient by name. Hello, sir. My name is Jeff. I'm the paramedic here to help you today. What is your name, sir? Do you know where you're at? Do you know what time it is? Is it daytime? Is it nighttime? Why did you call EMS? What's happening to you today? So I introduced myself, asked about the chief complaint. I addressed any life threats because I'm looking if there's any bleeding or if the patient's not breathing or not responding. I'm going to work with that. Okay, I'm going to address those life threats. Define whether the patient's condition is stable but potentially unstable, or unstable. I like to say sick or not sick. Let's make it simple. Sick, they're stable. Not sick, they're unstable. Can I change that later once I assess them? Oh yeah. It may change mid-route. It's okay. It's all right. But keeping things simple is always the best method. All right, so we're assessing the level of consciousness as a part of this general impression. We're doing that as we're talking to them. Person, place, time, and event. Okay, a level of consciousness can tell us a great deal about their neurological and physiological status. The assessment of an unconscious patient focuses on ABCs: airway, breathing, and circulation. Conscious with an altered LOC may be due to inadequate perfusion, medications, drugs, alcohol, or some sort of poisoning. To assess for responsiveness, use the mnemonic AFU. Are they awake and alert? And we use person, place, time, and event. So there's 4 different things that we're going to assess. Person, what's your name? Place, where are you at? Okay. Time, is it daytime? Nighttime? Okay. An event, what happened today? Describe what made you call 911. Or if they're not awake, we're going to assess, are they responsive to verbal stimuli? Hey, hey, are you okay? Are you okay? If there's no response, we're going to see if they're responsive to pain. So we'll give them a little pinch, we'll give them a little tug, that kind of thing, see if they respond to that. Or if they don't respond to any of that, then we know that they are U, which is unresponsive. Orientation tests the mental status of each one of our patients. It evaluates the patient's ability to remember that person, place, time, and event that we talked about earlier. All right, so identifying life threats. Well, first off, you need to scan as you're talking to the patient, establishing your LOC. Is there any active bleeding? And since you're a team leader, if there's active bleeding, you're going to tell your partner, control the bleed. That's all you're going to tell them. Control bleed. If it's squirting, you could even say tourniquet, control bleed. In most cases, we begin with the airway, followed by breathing and circulation. In some cases, it's much more appropriate to address the life threats to circulation first, CAB, such as in the event of bleeding. Assessing the airway. As you assess your patient, stay alert for signs of airway obstruction. Ensure that the patient's airway remains open, okay, or patent or adequate. Responsive patients, these are patients who are talking or crying, have an open airway. In the unresponsive patients, you need to immediately assess for the airway's patency. Is it obstructed or is it unobstructed? Assessing for breathing, make sure the patient's breathing is very present and adequate. You need to ask yourself a few things. Number 1, is the patient breathing? Then say rate and quality. How fast is it? How slow is it? Quality. How deep is it? How shallow is it? Okay. Is it adequate? Is the patient blue? Okay. Like good old Larry the Cable Guy said that he used to be a lifeguard until he got fired because of some blue kid. Hypoxia, cyanosis, they're blue. Okay. Blue is bad. Blue is bad and air ought to go in and out. That is good stuff. Okay. Good remembrance. Consider providing positive pressure ventilations with an airway adjunct when the respirations are greater than 28 per minute or fewer than 8 breaths per minute, or too shallow to provide adequate air exchange. This is when we get our BVM and provide bag valve mask resuscitation, positive pressure ventilations. Before this course is over, your BVM is going to be a real friend to you, okay? It is going to be your best friend, other than a couple other airway adjuncts that you use. It is a very important piece of equipment on your repertoire of tools that you can use. So, observe for signs of increased respiratory effort to include retractions. That's when you see, they're retracting, use of accessory muscles, their nasal flaring, their little nares are getting bigger. If they have only 2 or 3 word sentences, that's 2 or 3 word dyspnea. I can't. I'm trying to, that kind of thing. I do a pretty good job of it, right? Tripod positioning. This is when they're sitting with their arms down and they're leaning way forward. They're trying to keep their airway open. Sniffing position, that's when their head is back, like they're sniffing the air. And then, of course, labored breathing. One of the things that I want you to remember about breathing, an anesthesiologist told me a long time ago that one thing you can always be sure of, normal respirations are silent. Everybody look around, or if you're in a room or whatever, or listen to yourself, whatever. Do you hear anybody breathing? No, you shouldn't, because if you hear somebody breathing, there's a problem. There is definitely a problem that you need to look for. Well, the same thing when you're in the field. If you can hear somebody breathing, there's a problem. You got to address that problem, identify what the problem is, and then treat it appropriately. Respiratory distress and respiratory failure. All right, respiratory distress is the first phase of respiratory problems. You want to find somebody that's in normal respiration, but if they're not normal, the first phase before they go into failure is distress. Distress, they have an increased effort and rate, but they're still conscious, and they're not really blue. They don't have decreased ventilation. But when they go into failure, this is when the blood is inadequate, or blood has an inadequate amount of oxygen in it because the respiration has gotten so bad that the patient's becoming hypoxic. In this particular case, you're going to see changes in ventilation. The patient could be angry. They could be very, very confused, or they could be unconscious. That's because it's not meeting the oxygen demands, the oxygen supplies of the body. After respiratory failure is respiratory arrest. We don't want it to get there, so we want to identify it early and treat it effectively. All right, circulation. One of the biggest key indicators is mental status. Let me tell you something, folks. You can be breathing, but if you ain't circulating, your body's dying, okay? The body has to circulate. It has to pump blood because the blood carries all the vital oxygen and the nutrients that the body needs to survive. So we assess mental status first, pulse, and skin condition. Assess the pulse. Palpate and feel all the pulses. Feel the radial pulse. Feel the carotid pulse. Feel the femoral pulse. If you cannot palpate a pulse in an unresponsive patient, begin chest compressions or CPR. That person's going to need it. If they don't need it, they're going to hit you. They're going to say, stop pushing on my chest. Okay. Skin condition. Evaluate the patient's skin color, temperature, moisture, and capillary refill. Capillary refill is very simple. Okay, you take the hand. I'm going to try to do this. I like this. All right, and then you squeeze it. All right, see what color it is. Then when you let go, it's can't really see it. There's a better film on it because the sun's coming through. Anyhow, it turns white and then immediately turns pink within 2 seconds. That's the blood being pushed out of the capillary beds when you squeeze on the hand, and then when you let go, the blood returns. It should return within 2 seconds. Anything more than that, that is a delayed capillary refill. If you have poor circulation, it will cause the skin to appear pale, white, kind of an ashen color or gray. High blood pressure may cause just the opposite. It may cause it to be very flushed or red. All right, skin color. When blood is not properly saturated oxygen, it appears blue. If you'll look, this little baby here, his little face, he's little blue all around there. This is acrocyanosis, okay? Especially blue around the lips, and it's just because he's not oxygenated yet. He's just born. Look, his little head's still wet. He's just born, so here in a little while he will get nice and pink, but at first, without the oxygen saturated into the tissues, he looks kind of blue. Skin temperature. Normal skin would be warm to the touch. Abnormal skin would be hot, cool, or cold, or clammy. Skin moisture. Dry skin is normal. Skin that is wet, moist, or excessively dry or hot suggests that there's a problem. Capillary refill, we talked about that, okay? It's definitely there. It should be restored within 2 seconds. We'll practice that in the skill drill. Assess and control external bleeding in trauma patients. That happens in the beginning. This should occur before addressing airway or breathing concerns. If this person is squirting blood, what do? You stop the bleed. Direct pressure is your first thing. It is your friend. Okay, direct pressure. When you compress any vessel, it begins the clotting process. So you need to put direct pressure on first. If the bleeding does not stop and it's on an extremity, we can use a tourniquet. If direct pressure is not quickly successful, or if there's obvious arterial hemorrhage of an extremity. If it's squirting from an extremity, put it on. Put the tourniquet on. You'll become very good at that, very proficient in applying tourniquets. All right, performing a rapid scan. All right, this is the rapid scan of the body. It should take somewhere between 60 to 90 seconds. It's to identify injuries that must be managed or protected before the patient is transported, okay? 60 to 90 seconds. Determining the priority of the patient in care and transport. The high priority patients include those with any of the following. If they're unresponsive, if they have a poor general impression, if they have difficulty breathing, any uncontrolled bleeding, or if they're responsive but they cannot follow commands. They don't do that so well. It's like, okay, we'll touch your forehead, and he kind of goes like this. You know, he never touches his forehead. That's not following commands, so that's a neurological change that's not normal. High priority to continue: chest pain, pale skin, complicated childbirth, severe pain in any area of the body. The golden hour is what they used to call, but they have it now. It's the golden period. It is the time from injury to definitive care. Treatment of shock is number one in this with our traumatic injuries. We aim to assess, stabilize, package, and begin transport within 10 minutes of arriving on scene. We call this the platinum 10 minutes. This is on slide 39. It shows you the progression of the golden period. This says golden hour, but golden period. Transport decisions should be made at this time based on the patient's condition, the availability of advanced care, and the distance of the transport. You may have to use either ground, you know, your little ambulance, woo, woo, there he goes, he has wheels, there he goes, or you may have to use air. So, so I can do this. All right, there we go. All that. You got your little this, okay, and your little rotor on the tail. There you go, man. That's a helicopter. All right. Put a little windshield in there and put a little head in there. There you go. There's the pilot. Somewhere in there's the crew. Okay. There you go. All right. Priority of patient care and transport. History taking, big stuff, man. It provides detail about the patient's chief complaint. It includes a lot of demographic information, the date of the incident, the age, the gender, the race, past medical history, past surgical history, and past psychiatric history. I asked all that. And then what their current health status is. Are you a well person or are you a sick person? You know, ask them. It's okay. Ask them. There's no harm in asking questions. This is the only way you're going to get answers. And like I said earlier, you are playing the detective. You got to put the hat on, you know. You got to get the information so you can figure out what's wrong with the patient and how you're best going to help them. Investigate a chief complaint. Why did you call 911? Make your introduction. Make the patient feel comfortable and obtain permission to treat. Remember back from the chapter on legal and ethical, we have to get permission. If the patient is unresponsive, gather information from other people or clues in the surrounding. Use the OPQRST mnemonic to assess symptoms. Onset. When did it happen? When did it start? Provocation or palliation. Does anything make it better or worse? Quality. Let them explain to you what it feels like, okay? What the pain feels like or the shortness of breath. Let them describe it to you. Region. Where is it at and does it radiate to another area? Severity. We use this on a scale of 1 to 10, 10 being the worst. Give them a number because that way when you treat them and then later ask them the same question, they say it's a 5, guess what? You did a good thing for the patient. And then lastly, timing. This is timing. Is it constant or does it come and go? And then in this time, you're going to apply what's called the pertinent negatives, and we'll talk about that later. All right, so we also use the mnemonic sample for history, signs and symptoms, do they have any allergies, medications, pertinent medical history, last oral intake, and events leading up to the injury or illnesses. So our tools are sample and OPQRST to get all of our information. Special challenges, a patient that don't want to talk to you, or a patient that really wants to talk to you. And then multiple symptoms. If they have so many symptoms and they're telling you all about it, you need to focus them or redirect them to what is your main complaint. Well, the patient may have quite a bit of anxiety, maybe some anger or hostility. And then, of course, we get lots of intoxicated patients, and those you have to just be patient with. And then you may have a very upset patient, very emotional and crying, so that can be a challenge. You also have patients that are depressed. They have confusing behavior or history of delirium or delusions or some kind of psychiatric history. They may also have a patient with special needs or limited cognitive abilities, cultural challenges, language barriers, hearing problems, and visual impairments. Secondary assessment. So now we're leaving primary. We got all of our primary done. So secondary may be performed at the scene or in the back of the ambulance en route to the hospital, or not at all. The biggest thing is that you should never delay transport to do a secondary assessment on the scene or anywhere else. So if you're stuck in your primary and your patient is critical, start to the hospital. If you get time to do the secondary assessment, great. But if you don't, it's understandable because the patient was so critical. The purpose is really to perform a systematic physical exam of the patient. It may be a systematic head-to-toe secondary assessment or an assessment that focuses on a certain area of the system of body. So basically, you're either going to have a multi-system problem or a single system problem. You're either going to have a car accident with all these injuries all over the place, or you may have something as simple as I broke my finger, in the bathroom or whatever. So the broke my finger is called single system. All right, so how and what to assess inspection, palpation, auscultation. Inspection is just taking a look. Yes, you have to take a look. You need to take the clothes off the patient. All critical patients are stripped and clipped. They have zero clothing on. Okay, get used to that. Absolutely. Patients that are singular system, that are stable or not sick, you're only going to expose the areas that you need to expose to do these following items: inspection, palpation, and auscultation. All right, use the mnemonic DCAT BTLS. That's deformities, contusions, abrasions, penetrations, burns, tenderness, laceration, and swelling. And then you're going to compare the findings on one side of the body with the other side when possible. Systematically, you're going to assess the patient for your secondary assessment. The goal is to identify any hidden injuries or identify causes missed during your first initial 60 to 90 second exam during that primary survey. Focused assessment. This is performed on patients who sustained a non-significant mechanism of injury or on responsive medical patients. Typically, it's based on a singular system chief complaint. The goal is to focus your attention on the body part of the system that's being affected. Respiratory system. Folks, you got to expose the patient's chest. You need to be able to listen to lung sounds. And besides that, if you loosen up clothing, it helps them breathe. Look for signs of airway obstruction. Inspect the chest for symmetry. Does one side go up and the other side doesn't move or goes down? Listen to breath sounds. Measure the respiratory rate. Look for retractions and increased work of breathing. Check the cardiovascular system. You're looking for trauma to the chest and listen for breath sounds. Okay. Consider the pulse, respiratory rate, and blood pressure. Pay attention to rate, quality, and rhythm. Consider your findings when assessing the skin. Check and compare distal pulses, and consider auscultation, or listening to the lungs for an abnormal heart sound. So you can listen to lungs and the heart. It's both called auscultation. You can listen to the heart for sounds. You can listen to lungs for sounds. You can also listen to the abdomen for bowel sounds as well. All right, so use the rate normal resting pulse for adults between 60 and 100. This is table 9-5. It's on slide number 55. This is your normal ranges. Pulse quality, rhythm, and blood pressure. These are major factors in looking at the cardiovascular system. Normal blood pressure, here you go. Table 9-6 on slide 57. Nice little tool for your toolbox. Neurological assessment should be performed with any patient who has changes in mental status, possible head injury, or stupor. And stupor means just a confusion state, not quite with the program. Dizziness, drowsiness, or syncope. Syncope is passing out. Learn the words, medical terminology. Other neurological assessments evaluate the level of consciousness and orientation, person, place, and time and event. Use the AVPU scale if appropriate, and then use the Glasgow Coma scale, which will be helpful in providing additional information that you'll relay to the hospital. All right, so pupils, normally round and approximately equal size. The diameter of the activity of light can reflect the status of the brain's perfusion, oxygenation, and condition. It can also give you hints if the patient is using narcotics, which if they're using narcotics, the pupils will be pinpoint. They'll be very small, versus if they're using a stimulant like cocaine or meth, that kind of stuff, they'll be very big. They'll be very large and won't respond to light. In the absence of any light, the pupils will become fully relaxed and dilated. There you go. There's your pupils constricted, as you can see there, and then dilated. And then let's take a look here. Close me out there so you can see it better. Unequal. This can be a natural condition. This condition is known as anosacora. Okay, it's where there's damage to the optic nerve. So therefore, this little guy through genetics is unequal from the other, or it could be a significant sign of a brain injury. All right, let's bring me back. There I am. Okay. All right, smaller number of population exhibit unequal pupils. Again, like I was mentioning before, anosacora. Abnormal pupillary responses can indicate brain function problems such as herniation. We'll talk about that in head trauma. All right, so Pearl is useful assessment guide. Again, Pearl. Pupils are equal and round, regular in size, and reactive to light. Pearl. All right, neurovascular status, check for bilateral muscle strength. Have them, grab your hands and squeeze them, and or both sides equal. Complete and thorough sensory assessment. Can you feel my touch? Can you feel temperature? Test for pain and sensation and position. Compare distal and proximal sensory and motor responses on one side or the other. Anatomic regions, we start from the head, we go from the chest, then the abdomen, the pelvis, the extremities, and then the posterior portion of the body. Assessing of vital signs, appropriate monitor devices. Everybody knows what this is. This is your SaO2 monitor. You have them, or pulse oximeters. Other vital signs are measured through capnography. We'll talk about that later in the respiratory module. Also blood glucometry, non-invasive blood pressure monitoring or measurement. All right, so reassessment. This is the end of the assessment, okay? It's performed at regular intervals during the assessment process. We're going to repeat that primary assessment. How are our ABCs? Are they still good? We're going to take another set of vital signs, compare them to their original baseline vital signs, and then look for trends, either up or increasing or decreasing. All right, so reassess the chief complaint during reassessment, recheck any interventions, the tourniquet application, oxygen, bandaging, anything you've done, identify and treat any changes in the patient condition. This is reassessing the patient. Unstable patients, approximately every 5 minutes, you're going to reassess. And then stable patients are not sick, approximately every 15 minutes. Okay, folks, that ends this lecture. Please review the following review questions. You can answer them. We'll discuss them in class. I really appreciate you being part of the class and also spending this time with me in my home. This being recorded at home. This, you always tell when the picture behind me is present, I'm at home. When my credenza is present, I'm at work. Anyhow, thank you much. Be sure you clock out to get full value of time, and clock in so that you can get for your test, so that you can take your Quizlet. Okay, have a great one. We'll see you next time.